Welcome everybody to the VASCERN webinar on collagen, Ehlers-Danlos Syndromes, and vascular fragility. What's in a name? Today's presenter will be Professor Fransiska Malfait from the Center for Medical Genetics at Ghent University Hospital in Belgium. So just a few general instructions before we start. To let you all know that the webinar will be recorded. So the video will be available on our YouTube channel afterwards. For anyone who missed it or who would like to see it again. Any questions you have, we'll have a question and answer session at the end. So please put them in the chat box and we can collect them and we'll try to get them replied. And finally, if you have any technical problems, you can also use the chat box or you can send me an email and we'll try to help you with that. So just a very brief introduction to VASCERN for those of you who don't know us. So we're the European Reference Network on Rare Multisystemic Vascular Diseases, one of the 24 ERNs. We currently gather 26 healthcare providers, those are the hospitals, which are full members, plus 7 affiliated partner centers coming from 16 EU countries. And then we also have over 70 patient organizations from all across Europe working with us as they participate in each of our rare disease working groups. We're made up of 5 rare disease working groups, which cover all the rare diseases in our network. So there's the HHT group, which is the hereditary hemorrhagic telangiectasia working group. The HTAD working group, which is the heritable thoracic aortic diseases working group. They cover diseases such as Marfan syndrome, Loeys-Dietz. The PPL working group, which is pediatric and primary lymphedema, covering different pediatric and primary lymphedema disorders. And then the vascular anomalies working group, VASCA, which has over 40 different types of vascular anomaly disorders that they cover. And finally, from today's group, it's the Medium-Sized Arteries Working Group, which currently covers vascular Ehlers-Danlos Syndrome. So you can find, of course, all information on our website at https://vascern.eu. So I invite you to check that out as well as our social media channels. And now, without further ado, I'll present our today's presenter is Professor Dr. Fransiska Malfait. We're very happy that she could do this presentation for us today. She's a clinical geneticist, so she's also from the Center of Medical Genetics at Ghent University Hospital, and she's the co-chair for the Medium-Sized Arteries Working Group. So I'll pass it to you now, Fransiska, please.
Thank you very much. Thank you for the invitation to give this webinar here today. And so indeed, I am going to talk about collagen, different types of Ehlers-Danlos syndrome, and vascular fragility, and hope to illustrate that it's not only vascular EDS when we see vascular fragility in people with Ehlers-Danlos syndrome. So before I start, I would actually like to start with a little quiz. So I'm going to present here 4 cases for families or patients, people with Ehlers-Danlos syndrome. And you can think a little bit about what type of EDS you would suspect and write it down. And then at the end of the presentation, I will come back to these 4 cases with the answer. So the first one is a patient, a male patient who at the age of 37 years suffered from a spontaneous rupture of the right iliac artery. In his family history, we heard that his father had signs of Ehlers-Danlos syndrome, including joint hypermobility and skin hyperextensibility, but also had a bowel rupture at middle age. And then upon clinical examination of this person, we noted that he had a thin skin, which was also hyperextensible and generalized hyperextensible skin, the presence of the typical atrophic scars. Unfortunately, I do not have any pictures of this person. He bruised very easily, and he had a moderate hypermobility of the joints with the Beighton score of 4 out of 9, and also a pectus deformity. So this is the information that we have. So we know there is a vascular rupture at 8:37 of a medium-sized artery. There is this family history of bowel rupture, and there is the typical signs of Ehlers-Danlos syndrome. So what type of EDS could this be? I'm not going to give the answers now. I'll come back to it later. Then there is another person here, a female, who also had a spontaneous rupture of the right iliac artery at the same age 37. And so this is the lady that you see here on the picture. And in a family history, we also saw her 17-year-old son, who clearly presented with a skin hyperextensibility and joint hypermobility. And the skin hyperextensibility was much like we also observe it in a classical type of Ehlers-Danlos syndrome. She, on the other hand, had not really hyperextensible skin, but a thin and translucent skin, a bit like we see in vascular type of EDS, some mild atrophic scars that you can see here on this picture. She also bruised easily, and she had only a Beighton score of 2 out of 9, so not really generalized joint hypermobility. So could this be the same as the previous person? Is it a different type of EDS? What would be your guess? Third patient is a 25-year-old male who presented to us with generalized joint hypermobility, Beighton score now 9 out of 9. He clearly had a really quite severe skin manifestation, as you can appreciate immediately from the pictures. Very soft and doughy skin, hyperextensible skin, multiple scars, atrophic scars with this brownish discoloration, especially here on the legs, also easy bruising. And then he also developed at young age an arteriovenous fistula in the neck. And then upon further examination with MRI, we also found multiple aneurysms of medium-sized arteries. So again, your guess. And then finally, this is not one of our patients. This is a published family from our British colleagues concerning this patient here. Again, a male person with skin hyperextensibility. I think that's clear. Who died from the rupture of the colon at age 74. But then looking at several of his family members, there was also signs of Ehlers-Danlos syndrome with a thin skin, easy bruisability, variable skin hyperextensibility here in a young child, for instance. And I think here on this picture, you can appreciate his large hematoma on the forehead. Also some atrophic scarring with some discoloration, and then a family history of bowel or esophagus rupture. So again, what would be your best guess for the diagnosis here? So, but I promise I'll come back to these. So as an introduction, I would like to briefly discuss what Ehlers-Danlos syndrome is, introduce the classification that we currently use, and give you first a brief introduction into the more common molecularly explained types of EDS, the vascular and the classical type, and the vascular fragility that is associated. And then after that, I will discuss some rare mutations, variants that we find that make all of this a little bit more difficult to diagnose, as you will see as I explain. So what are the Ehlers-Danlos syndromes? So the Ehlers-Danlos syndromes are a clinically and genetically quite heterogeneous group of disorders of the connective tissue. And these are heritable disorders, of course, since they are caused by genetic defects. And the main manifestations that characterize an Ehlers-Danlos syndrome are the presence of cutaneous manifestation, usually skin hyperextensibility and fragility, but other cutaneous manifestations can include a thin skin, a very fragile skin, and the formation of atrophic scars. Then there is this presence of joint hypermobility, which is usually generalized, so affecting small joints and large joints, but it can also be limited to a few joints. So and so we have to be careful. It's not because a person is not hypermobile that it immediately excludes an Ehlers-Danlos syndrome. And then because the connective tissue is really present throughout the body, we can see all signs of tissue friability or fragility all over the body. And so here you can see a few of the first pictures of people affected by Ehlers-Danlos syndrome. So this is actually the first picture of this man. His name was Felix Weerle, and he was the elastic skin man. And then you also had the India rubber man, the elastic lady, the human pretzel. So these people used to be on fairgrounds and circuses because they could show off with their remarkable ability to stretch their skin or to bend their joints. So we now know that Ehlers-Danlos syndrome is much more than the skin and the joints. And as I have already said, because the connective tissue is present everywhere in our body and is considered like the glue of our body, people affected by different types of EDS can have manifestations virtually in every tissue or in every organ of our body. And so we can see craniofacial abnormalities, dental abnormalities. We can see internal problems. For instance, you can see ptosis of organs. You can see prolapses, diverticulae, for instance, in the bladder, but also in the gastrointestinal tract. We can have a combination of joint hypermobility with joint contractures. Sometimes there is also some fragility of the bones with osteoporosis and sometimes fractures. Then, yeah, of course, all the skin manifestations. We can have muscle weakness. And then, of course, very importantly here, the vascular involvement, or sometimes also involvement of the heart, with valvular problems, and then the fragility of large and smaller joints. At first, biochemical and ultrastructural studies that were performed on skin biopsies of patients affected by an Ehlers-Danlos syndrome hinted towards an abnormality in collagen. And collagen, of course, is a very important structural protein in our connective tissues. And so in the late 70s and the early 80s, especially, like I said, biochemical and ultrastructural studies pointed towards an abnormality in collagen in EDS patients. And then with the introduction of genetic techniques to identify errors in our genetic code, indeed, abnormalities or mutations were being identified in genes that code for particular types of collagen, which we call the fibrillar collagens. And these are mainly collagen type 1, type 3, and type 5, or in other proteins, which we call enzymes, that are involved in modifying these collagens so that they can get their mature function and their mature structure. However, as you can see, in the beginning of this century, with more sophisticated techniques to search for genetic abnormalities in our genetic code, actually many novel genes and proteins were being identified in patients, usually with rare forms of Ehlers-Danlos syndrome. And what we also saw is that the more recently identified genes are actually not genes that code for collagen molecules, but in the end, they are all in one way or another involved in the biosynthesis or in the organization of collagen in our connective tissue. So also, identifying these different molecular or biochemical defects in these different patients with EDS allowed to start a classification of Ehlers-Danlos syndrome. And so there have been quite a few classifications by now. The one that has been used for a long time was the Villefranche classification, which recognized 6 subtypes. But because there was so many additional types identified in the last few years, in 2017, the International EDS Consortium published a new classification. And so this is the classification that is being used right now. It recognizes 13 different clinical subtypes with genes having or genes with associated genes, 20 associated genes. Actually, after the publication of this updated classification, yet another 14th type of Ehlers-Danlos syndrome was identified. So right now we know 14 different subtypes with 20 different genes involved. And probably this will still expand because quite regularly we and others still see other patients who clearly have a form of Ehlers-Danlos syndrome, but in whom we do not identify mutations in any of the known genes. And this is particularly true, but not exclusively true, but particularly for the hypermobile type of EDS, where the genetic defect, unfortunately, is still unknown. So for each of these different types, major and minor clinical criteria were put forward. A major criterion being a symptom or a sign that is present in the vast majority of individuals with that particular type of EDS, and allowing differentiation from other EDS subtypes, whereas a minor criterion is of lesser diagnostic specificity, is not so specific for one subtype. For instance, bruising, we see that in almost every type of Ehlers-Danlos syndrome, yet you will find it in the minor criteria for most of these subtypes. However, as I will illustrate in the next slide, there is a lot of overlap between all the different subtypes clinically. And the more people we identify and the more genetic defects we identify, the bigger that overlap seems to become. So therefore, it is also put forward that a definite diagnosis of a certain subtype relies on molecular confirmation with the identification of a specific mutation in a specific gene, if at all possible, of course. So why is this molecular confirmation so important? So first of all, it is very important to provide the most accurate counseling, because it confirms the specific diagnosis, but it also confirms the transmission pattern and the inheritance risk for other family members or for future children, because some types of EDS are autosomal recessive and others are autosomal dominant. And so the risk for other family members differs depending on that transmission pattern. For some of the more severe subtypes, identification of an underlying mutation opens the road to prenatal genetic diagnosis or pre-implantation genetic diagnosis. At least this is the case here in Belgium. It's not true in every country, but you know, this might evolve, so it could be important. It is also important to define more personalized follow-up and management guidelines for an affected individual or family members. And then it can also be important for research, because it allows us to perform natural history studies and learn more about a specific course of a specific type of Ehlers-Danlos syndrome. It allows us to study the correlation between a specific genetic defect and the clinical manifestations or the severity of these manifestations. And it allows us also to make more homogeneous groups of patients for future clinical studies. So it can be really important for many different reasons to perform these molecular studies. So first, I'll start with vascular Ehlers-Danlos syndrome, because of course, when we think about Ehlers-Danlos syndrome and vascular fragility, we immediately think of the vascular type of EDS. So what is this? This is an autosomal dominant condition that is caused by mutations in the gene that codes for type 3 collagen, and this gene is called the COL3A1 gene. The major clinical criteria that were put forward for this type are a family history of a vascular EDS with a document variant mutation in the gene. However, we have to be careful. About 50% of the first person with vascular EDS in a family actually has no family history, because that person, about 50% have a new mutation, so have not inherited the mutation from one of their parents, but have a novel defect in their genes. So family history does not necessarily have to be present. Then one of the most important things, of course, is arterial rupture at young age, which can be preceded by an aneurysm or a dilatation, but is not always preceded by this aneurysm. So it can also occur at a location in the vessels where we did not see any abnormalities. And it may occur spontaneously. We see it mostly in what we call middle-sized arteries. So these are the immediate branches of the aorta, especially in the thorax and in the abdomen, but you can also see it in the cerebral vessels, the neck vessels, such as the arteria carotis or vertebralis, and also in the extremities. Another important feature is the colon perforation, especially of the sigmoid colon, but it can actually be located in any part of the gastrointestinal tract. And then a third important thing is uterine rupture, especially during the third trimester of pregnancy in the absence of previous cesarean sections, and or the presence of severe perineum tears at birth. And then a rather rare feature, but very specific for vascular EDS, is a carotid cavernous sinus fistula formation in the absence of trauma. So other features of vascular EDS that are variably present are a quite characteristic facial appearance, where people can have these large, rather protruding eyes, quite a thin pinched nose, thin lips, hollow cheeks, and lobeless ears. So these are quite clear pictures, but it can be much more subtle in many individuals. A very thin skin, which is usually not hyperextensible, a thin skin where you can see the veins, especially over the thorax and the upper arms. And sometimes the skin can also have an aged appearance. This is, for instance, the hand of a young man of about 20 years old, but the skin looks really old. And this can also be quite particular. So I've already told you about collagen. So vascular EDS affects type 3 collagen, but what I'm showing you is true for also the type 1 collagen and type 5 collagen that we see associated with EDS. So collagen forms these thick fibrils, which are very important to give the structure and elasticity to our connective tissues. But if you look into more detail, these collagen fibrils consists of collagen molecules, and one collagen molecule actually consists of these chains, which we call alpha chains. And in one collagen molecule, you see that there are 3 alpha chains that are wound around each other. And so they form, so here you see the 3 different chains, and so they are wound around each other in what we call a triple helix structure. And it's very important that this helical structure is maintained in order to be able to form these collagen fibers. And so very important is that so for each chain, every third amino acid, which is like the building block of a protein, the amino acids are like beads on a chain and they form the proteins. So every third amino acid is glycine, which is a particular amino acid and is actually the smallest amino acid. And if you see here, the G stands for glycine. In these 3 alpha chains, the glycines, they always come together in the center of the helix. And because they are the smallest one, it's very important that every third position is a glycine, so that this helical structure can have its very, very rigid structure, as you can see here. So what we actually see, typical errors in collagen molecules, and what we often see in Ehlers-Danlos syndrome in the collagen genes, is that there are mutations that lead to the substitution of one of these glycines for another, bulkier, this should be, larger amino acids. So if we see an error in a collagen molecule, such as collagen 1, 3, or 5, that leads to the substitution, the replacement of a glycine by another amino acid, we immediately know that this is actually a mutation and this is responsible for the EDS. If other amino acids are substituted by another amino acid, so if it's a non-glycine substitution, deciding whether this is actually a mutation or not is a little bit more difficult. So there are a few large studies, including this one, that have looked at correlations between genotype and phenotype, between the particular defect in type 3 collagen and then the severity of the vascular EDS in terms of age or the mortality age in patients with EDS, and there we can make some correlations between the type of mutation. I'm not going to go into too much detail, and then the age of disease in these patients. And here, for instance, you can also see for glycine substitutions in particular, the bulkier the substituting residue, the more severe the phenotype or the clinical presentation will be. So it's actually important to study this. So this brings me then to the classical type of Ehlers-Danlos syndrome. The classical type of Ehlers-Danlos syndrome is characterized mainly by this usually quite severe skin hyperextensibility. And then people usually have these typical thin, large, white, thin atrophic scars, which can also show this discoloration, especially on the shins and the knees. They bruise very easily, just like in vascular EDS. And then they can have other manifestations of generalized connective tissue fragility, such as herniations, prolapses, etc. The genetic defect here lies either in the COL5A1 or the COL5A2 gene, and together these 2 genes code for type 5 collagen, which is another of these fibril-forming collagens. I'm not going to go too much into detail about classical EDS, but with regards to the vascular manifestations, when we look at the literature, there was a recent update on all published cases of classical EDS who also had severe arterial complications such as aneurysms of dissections. There are about 20 patients known right now with classical EDS who had severe arterial complications. And these complications were actually much like what we see in vascular EDS. So dissections or aneurysms in medium-sized arteries and the immediate branches of the aorta, with very few cases of aneurysms or dissections of the aorta. So we don't actually see aortic involvement in classical EDS, but we do occasionally see these ruptures. So we still have to be very careful in classical EDS for vascular fragility and be aware that there is this possibility. So far, there are too few cases to make any correlations, for instance, between the specific type of genetic defect and the risk of these arterial complications. So now, what about other mutations? And now I'm going to discuss some very rare types of Ehlers-Danlos syndrome that we are starting to see, actually, because more and more people get sequenced when they are diagnosed or when there is a suspicion of EDS. And that will show you that, yeah, the more we know, the less the distinctions between the different subtypes are clear. Let me start with this one. So these are two children that were identified and reported in the medical literature in 2000, so more than 20 years ago. They were seen by my supervisor, Professor Anne de Pape, and these children really presented with a phenotype resembling classical EDS. They had all the characteristics, including the generalized joint hypermobility, and it's difficult to see on these pictures, but they had the typical skin hyperextensibility, atrophic scarring, brownish discoloration, and easy bruising. However, we did not identify type 5 collagen defects, but we did identify a mutation in one of the two genes that code for type 1 collagen. Which is yet another fibrillar collagen. And so here, so this is an arginine to cysteine substitution at position 312. So that means that amino acid number 312 in this gene, usually there, or in this protein, usually there should be an arginine, but here it was substituted by cysteine. So remember that I explained that the typical abnormalities that we see are glycine substitutions to another amino acid, but these arginine to cysteine substitutions we actually had not seen before in the context of EDS. However, these two independent patients showing the same phenotype both harbored the same defect. So this was then published as classical Ehlers-Danlos syndrome caused by a mutation in type 1 collagen. A few years later, there was this lady, and you might recognize her from one of my first slides, and her son, who presented to our clinic. She was actually referred to exclude a vascular type of EDS because she had the spontaneous dissection of the iliac artery at 37 years of age. And when we examined her, she presented like this thin skin, bruising, not so much of joint hypermobility. So this yeah, could be compatible with vascular EDS, but then her son had this quite severe skin hyperextensibility, which more resembled classical EDS. And when we looked at type 3 collagen, we couldn't find any mutations there. And then, much to our surprise, we did identify the same arginine to cysteine mutation that we had previously identified in these two children. And then we also identified other arginine to cysteine substitutions in two other independent patients who also had arterial rupture of these medium-sized arteries. So it looked like arginine to cysteine substitutions in type 1 collagen can give a vascular-like type of Ehlers-Danlos syndrome. So what is it? Is it classical-like? Is it vascular-like? What should we call it? And how should we follow it up? So to date, about 20 patients, 20 individuals have been identified, have been reported in the literature with this specific mutation. And so clinically, yes, they do present as an overlap phenotype between classical or vascular EDS. Sometimes it's difficult to know from a clinical point of view. And about 25% of them have presented with severe vascular complications, including dissections and aneurysms of medium-sized arteries. So, we have recently seen this young boy here for follow-up. He is now in his mid-20s. So he actually presented I mean, clinically with what I would call a classical EDS, I mean, he really had a very soft and hyperextensible skin, generalized joint hypermobility, discolorations, easy bruising. He also had a pectus anomaly. But when we did an MRI, he did not show any signs of dilatations or aneurysms and has never had any vascular complications. And then our colleagues in Italy also published some patients who really presented like classical EDS and who did not show any vascular complications. So we will have to follow this up and see as more patients are being identified with this particular subtype, how big this risk for vascular complications is, and whether it is truly as big as what we see in the vascular type of EDS. Okay. So this then brings me to another type of EDS, which is the kyphoscoliotic type. Kyphoscoliotic type of EDS is one of the more rare subtypes. There are two genes that are responsible, two different genes, the PLOD1 gene and FKBP14, and both are in one way or another involved in collagen maturation. So they are both actually collagen-related proteins. And to date, about 75 patients with mutations in this PLOD1 have been identified with clinical phenotyping, and 12 of these have been reported again with rupture of medium-sized vessels. And from what we observe now, it was a little bit more prevalent in teenage years. 24 patients have been identified with FKBP14 mutations, and here 4 of these also had medium-sized vessel ruptures, and here you can see their ages. So again, there is a small but important fraction of these patients that present with vessel ruptures. And then there was this recent publication from colleagues, I think it was in Canada, about a novel recurrent mutation in the type 5 collagen gene called 5A1 that is associated with arterial dysplasia associated arterial disease with dissections and fibromuscular dysplasia. So these were actually 4 independent and non-related individuals who presented with an overlap phenotype between vascular Ehlers-Danlos syndrome, classical Ehlers-Danlos syndrome, but then some other conditions such as Lewis-Dietz syndrome and fibromuscular dysplasia. And actually only one of these fulfilled the clinical criteria for classical EDS, although they did harbor a mutation in type 5 collagen. And so all of these 4 individuals again harbored the same mutation in type 5 collagen, which we had none of us had seen before in classical EDS, which is this glycine to syrian substitution at this position 514. So as I show you, so only one of these actually fulfilled the classical EDS criteria, and so the others would not have been suspected to have a classical EDS, and so there would not have been any particular reason to look at type 5 collagen in these patients. So and then a last observation that is quite recent, and this is by our colleagues in the UK, who reported 7 families. And all of the individuals that were first presenting to the doctor, which we call the proband, were initially suspected to have a classical type of Ehlers-Danlos syndrome. But here the type 5 collagen genes were excluded. And by doing more extended molecular analysis, they did find specific abnormalities now in the type 3 collagen gene, the COL3A1 gene, and here it concerns substitutions of a glutamine, which is different than a glycine, again to lysine. And so they were at different positions, but it was remarkable that in these 7 families, they all harbored glutamine to lysine substitutions in the COLTRA1 gene. So the authors of this article, they saw this pattern, like this is weird that all these families have the same type of abnormality in type 3 collagen. And so they published this with extended phenotypic clinical details. And so what we see in these patients, I think you can appreciate that they have the skin hyperextensibility, much like we see it in classical Ehlers-Danlos syndrome. They have the atrophic scarring, they have quite severe joint hypermobility. Then on the other hand, this lady, maybe you could think that she has a little bit the facial characteristics of somebody with a vascular EDS with the large protruding eyes, then this large hematoma here on the forehead in this young boy. So is it vascular? Is it classical? We don't know what to call it. And then several of these people also had so vascular manifestations with aneurysms, ruptures, dilatations of middle-sized arteries, varicose veins, which we also see in vascular EDS. And then there were some gastrointestinal ruptures and also 2 people with a pneumothorax, all showing that there is also this fragility of the internal organs. So this brings me then a little bit to the discussion about should we use a clinical classification or should we use a genetic classification? So as you may have seen, or as you know, for each EDS subtype, we have a clinical descriptor, and so a denominator that refers to the most prominent clinical manifestations, and that is because historically these terminologies have been used, and when we published a new classification, we decided to continue to use these names because they are so embedded in our daily lives that it would be difficult to start using a whole new terminology. And so you have the classical, but then the cardiac, valvular, vascular, hypermobile, etc. On the other hand, here you can see the associated genes. And as I have explained, this list of genes is expanding. And now also within one gene, for instance, the COLTRA1 gene, as I have shown you, we see that it can be associated with different clinical subtypes of EDS, so it becomes quite difficult. So in a clinical classification, the emphasis lies on the clinical presentation and the total gestalt of a person. And so individuals are grouped mainly based on their clinical features. And usually for an affected individual, it's easier to identify themselves with a clinical type of EDS rather than with a gene. On the other hand, especially in research, scientists and doctors prefer usually genetic classification where the emphasis lies on a genetic basis. And here individuals are grouped based on the underlying genetic defect because it allows to make more homogeneous groups of people. So what are the implications for molecular testing? I think I have shown you that there is a lot of overlap between all these different types. Even also, sometimes it can be difficult to make a distinction between Ehlers-Danlos syndrome and other heritable connective tissue disorders or aortopathies such as Marfan syndrome, Lewis-Dietz syndrome, and other conditions. So therefore, it's so important to sequence the genes. And nowadays, it's usually gene panels that are being sequenced. It means that within one test, we can sequence all the EDS genes, or even including all the genes associated with EDS and aortopathies or other connective tissue disorders. And so again, here I show you some pictures of 4 different patients, all harboring a different genetic defect, but you can see based on the skin manifestations, it's very difficult to know beforehand where the exact mutation would lie. And then I'm going to just show you some other examples from observations in other research groups that published their data, where they did sequencing of gene panels in patients that presented with EDS. And so, for instance, in 2 patients with a clinical diagnosis of classical EDS, where we would expect a type 5 collagen defect, they did identify a type 3 collagen defect. And of course, it's very important because it influences the way that you will do the follow-up in these patients, and also preventive measures. We will be more prudent in patients with type 3 collagen defects with regards to physiotherapy, for instance. One patient with a clinical diagnosis of vascular EDS actually turned out to have a classical EDS with a type 5 collagen mutations. And then 3 patients who clinically were suspected to have vascular EDS turned out to have a mutation in the fibrillin 1 gene, which confirmed the diagnosis of Marfan syndrome, which is totally different, of course. And then in another research group, they tested 102 individuals for thoracic aortic aneurysm. And I'm not going to go into detail, but in one of these, they also found a mutation in the type 5 collagen gene, which is usually not associated with aortic aneurysm, as I have already explained earlier. So it's just showing us that we have to be careful starting from our clinical diagnosis, that we can also be surprised about the underlying genetic defect, and it's very important to do the testing. So this brings me to the end of my presentation, and I promised you that I would come back to my case presentations from the start. So this first person, a male with a right iliac artery dissection or rupture at age 37, family history of bowel rupture, and then this thin hyperextensible skin, some scarring, and a moderate joint hypermobility. He did harbor a type 5 collagen mutation. This lady here and her son, yeah, you have seen during the presentation, has this arginine to cysteine substitution in COL1A1. The next person, this 25-year-old male with a very severe joint and or skin manifestations and then multiple aneurysms of medium-sized arteries, has a mutation in PLOD1, which confirms the diagnosis of Kyphoscoliotic type of Ehlers-Danlos syndrome. And then finally, this patient had this particular glutamine to lysine substitution in type 3 collagen. And actually, we don't know yet how to call this type of Ehlers-Danlos syndrome. Maybe we will have to come up with still another name, but yes, time will tell, I guess. And so this brings me to the end of my presentation. I would like to thank the International EDS Consortium and the Ehlers-Danlos Society, and also, of course, VASCERN. This is my research group in COVID times, as you can see. And so, yes, I'm happy to take your questions.
Thank you so much. That was a very interesting presentation, highlighting the complexity of the EDS subtypes and their genetic diagnosis. So yes, let's see if we have some questions in the chat box. We have one question that is, sorry, let me just open the chat. So I have a vascular malformation in my neck. I have HEDS and a mutation variant in the COL5A1 gene. Is this rare in my type or not really that rare?
That's not an easy question to answer. I would say I know who this is coming from, so I know the patient and I know the clinical manifestations. So what would I like to say about this? I think clinically, when somebody is diagnosed with Ehlers-Danlos syndrome, and one of the main manifestations external manifestations, I would say, is hypermobility of the joints. And if no clear mutations are identified, often just for convenience, I would say this patient is then diagnosed with hypermobile EDS, because that's the type where we don't know the genetic defect yet. And so this also means that the hypermobile group of EDS is probably still a very heterogeneous mix of different phenotypes, and probably, and I hope in time, when we identify variants, genetic variants in people within this group, they will turn out to still have different subtypes of Ehlers-Danlos syndrome. So I think it's still a heterogeneous group. So I'm not sure that having HEDS with a vascular anomaly in the neck or vascular problems, if we would really call it HEDS, and regarding the variant in COL5A1, that's something I cannot answer now, because it really depends on the variant, because we all have many variants in different genes, and most of the variants in our genes are not associated with disease, and it's just normal variation, which makes that I am different from another person, and is not a true mutation. So sometimes we have to wait and see whether the same variant pops up in other patients with the same manifestations or with EDS, to make a decision whether this is actually related to the phenotype or not. I don't know if this is clear, but so in HEDS, yes, it would be rare to have a variant or a mutation in COL5A1. Then it would not be a hypermobile EDS, but it's possible that there are still different subgroups within the HEDS subtype, and we will only find out as we unravel the complexity of the genetics within this group.
Thank you. It's a complicated question. So another one we have is, what is your advice for treatment in acute dissections?
I would say go to the hospital as quickly as possible. Yes, I'm not a surgeon, so I'm probably not the best person to answer this question in detail. So yes, usually if there is a severe dissection, it would be urgent surgery, depending of course on the location, etc. But I think that VASCERN also has probably good information on this, right, Natasha?
Yeah,
there are some
so we have the list of our expert centers, and also we have a mobile app where you can find the expert centers that treat VEDS, and so
exactly, especially for vascular EDS, this is clearly I mean, there are guidelines where you can find it. You can find guidelines for the other types of EDS associated with vascular EDS. Actually, there are no guidelines for acute dissections, because the number of affected patients is so small that it's usually just observations. But for now, in these patients, we follow the guidelines that are outlined for vascular EDS.
Thanks. Okay, so there's also a question asking if the COL5A1 variants associated with FMD, if they were class 3 variants or class 4 or pathogenic.
They were actually the glycine to syrian substitution, I believe that you are referring to, Michael. Is that correct?
Yeah.
Yeah, well, this was actually published as I think as a class 4, because of the fact, I think that they were found in 4 independent patients. But I think time will tell whether we will find the same variant in other patients with this presentation. we haven't seen it in our center yet, and I haven't seen any other publications yet, but it's quite recent.
There's also another question saying if the dominant negative effect of glycine substitutions in COL5A1 mutations are the explanation for arterial fragility.
Yes, I think there's a possibility. As I said, for now, there are no clear genotype-phenotype correlations yet between type 5 collagen defects and arterial fragility, although also in our cohort of patients, we do see that actually the majority of those that have severe complications are harboring glycine substitutions. There are a few exceptions, but there seems to, this pattern seems to become clear that, yeah, that it's mostly glycine substitutions, but we are only talking about a handful of patients. So in that case, yeah, a dominant negative effect could be the explanation, yes. And then, yeah.
Yeah, I don't know if there's a question. It's a sort of a specific question from a patient saying that myself, 45-year-old male, and my daughter, 16, have a mutation in the COL3A1 and SMAD3 gene. Is this some kind of overlap like the ones you were talking about? I don't know if
this is still a little bit different, because what I was talking about is people who have a specific defect in one gene, but who clinically presents like an overlap between, for instance, classical and vascular Ehlers-Danlos syndrome. So these people did not have two different mutations in two different genes. It's just that they have a mutation in a certain gene where you expect a certain phenotype, but you see another phenotype. What you or this person is referring to is mutations in two different genes, which could give, yeah, of course, also complex phenotype with overlap between the two conditions if there's two true pathogenic mutations. This is very rare, but it occurs. So yeah. So yeah, that complicates the diagnosis. And yeah.
So I don't think you mentioned cavernomas in your presentation, but someone asked if there's a relationship between cavernomas and EDS.
And EDS,
knowledge.
Not that I'm aware of. I don't know if Michael is still in the meeting, and maybe he could correct me if he has other information, but not that I'm aware of.
Okay. Incidentally, yes,
Yes.
Michael's replied.
Thank you.
Okay, I think for the moment, I don't know if there's any more questions. We're just about reaching 6 p.m. Time. So if we have any last questions, you can ask them in the chat. Otherwise, we can close this webinar. So yeah, I don't think there's anything more. So thank you so much to Dr. Fransiska Malfait for her really excellent presentation, giving such a great overview of these genetic subtypes of EDS. And remember that we will be having the video available soon on our YouTube channel. So keep your eyes open on our social media and everything. We'll announce that. And thank you to everybody so much for joining.
Thank you all. Have a nice summer.
Yes.
Bye bye.
Thank you to everybody. Have a good evening.